Indications in the chest are mediastinal lymphadenopathy, nodal staging for non-small cell lung cancer, lung masses adjacent to the esophagus, and mediastinal masses. Mediastinal stations that can be reached reliably are the paraesophageal mediastinum, the subcarinal mediastinum, and the left paratracheal mediastinum. Right paratracheal and anterior stations pose problems due to the distance from the esophagus and interposing air. Indications in the abdomen and pelvis are lymphadenopathy including celiac nodes in esophageal cancer, subepithelial tumors, gastric wall thickening suspicious for infiltrating disease, solid pancreatobiliary tumors, pancreatic cysts, and left adrenal gland masses. Liver masses can be sampled by EUS if a percutaneous approach does not appear feasible, either due to poor visualization or due to location. Complications after EUS-guided biopsy are infrequent. Pancreatitis occurs in 1% after sampling of pancreatic lesions. Occasionally, development of hematomas can be observed by EUS during the procedure. These usually remain asymptomatic. Symptomatic bleeding is very unusual. Infection is a concern after aspiration of cystic lesions or transrectal biopsy. The risk can be minimized by administration of prophylactic antibiotics for these indications. Perforation can occur after forceful passage of an obstructing tumor, but is usually due to preceding dilatation. Duodenal perforation due to traumatic advancement of the endoscope tip into the descending duodenum is rare. Needle tract seeding has been reported as a rare cause of tumor recurrence. In transduodenal biopsies of resectable pancreatic head cancer, the concern is low since the needle tract will be removed by Whipple surgery. The classical way of EUS-guided tissue sampling is fine needle aspiration, or FNA. The aspiration needles used for FNA are easy to handle in almost every endoscope position. FNA yields cytology specimens, which are sufficient to make a diagnosis in most cases. More recently, an EUS TrueCut needle has been developed, which enables to obtain tissue cores for histologic assessment. Evaluation of the tissue architecture may, for example, be helpful in accurate subclassifications of lymphomas, in spindle cell neoplasms requiring additional immunostains, or in microcystic adenomas of the pancreas, in which a cytologic diagnosis is almost impossible.